I request everyone to please switch off the cameras and the audio. We welcome Dr. Vibhu Mendiratta. She is Director Professor and Head of the Department of Dermatology at Lady Hardinge Medical College and Kalavati Children's Hospital. She'll be speaking on the fungal infections. And thank you very much. I request ma'am to please start the presentation.
Yeah. Thank you so much, Dr. Ajay and Dr. Bhandari, sir. And it's indeed a pleasure for me to be talking on this subject, which is so very important for dermatologists and equally important for the pediatricians, because we know that fungi are really raging around, and because of many factors, there have been climate changes, there have been an over abuse of antibiotics, and also we are, confronted with an increasing population of immunocompromised children. So these agents, which are fungi, and they are present all around us in the environment, they are very hard and they live very resistant organisms. And these infections, generally, they are caused by some organisms which are normally present on our skin. And skin is mirror to all the other changes inside the body. And these infections are commonplace in our day-to-day practice. So today I'm just going to give you an overview of some of these infections, which we generally encounter in the children starting from infancy and they go on up to the adolescence. So the learning objectives of my talk today would be that pediatricians should be able to recognize these common infections which they encounter in the office practice, and they should also be able to at least have a fair idea of the treatment options that are there, and at the same time, very important to know and decide when to refer to the dermatologist. That is also very important because they just cannot go on treating a patient who fails to respond. So what are fungi? Very briefly for you, we have unicellular organisms, which are yeasts. Then you have dermatophytes and you have saprophytic molds. And these molds, they are growing in the soil, in the water, on the dead decaying material. And these saprophytic molds are basically, they are opportunistic organisms. And these organisms will attack when the host defense is down. So today, let us just focus on the skin infections. And in the cutaneous infections, we have to focus on the superficial infections since they are very common. And the examples are tinea versicolor, and you have other cutaneous infections. They are caused by dermatophytes, and the subcutaneous infections are little deeper infections, and these I am going to just touch upon as they are not commonly seen in the outdoor clinics. So common infections, let us come to mucocutaneous candidiasis, because I'm sure all my pediatrician friends must have treated and seen so many of these cases of oral thrush and candidal intertrigo, diaper dermatitis, pityriasis versicolor, dermatophytosis. So I'm going to take you through each one of them in my talk. Now, we should have a basic understanding as to why these infections happen, first of all. So it is just not the organism, but it is the host also and the environment. So these three things, they interact together to give rise to infection. So local factors, because they are very important to be modified when we are treating these infections. So what are the local factors that we see in our patients are that generally the skin is traumatized. So trauma can be a direct trauma, or it could be due to occlusive, very tight clothing, which rubs against the skin and causes damage to the skin barrier. Then public showering leads to contact, because all these infections are contagious infections. And then we have moist conditions. So when it is summer season, there is a lot of sweating, that also leads to maceration. So these factors, they need to be taken care of. Then we come to the host factors. So we know that since most of these fungi, they are not pathogenic, but in case there are certain breaches in the host defense in the form of somebody who's on steroid therapy, receiving immunosuppressive agents, receiving chemotherapy, or having HIV or primary immunodeficiency, and even uncontrolled diabetes mellitus, obesity also can predispose the children to acquire these infections. So oropharyngeal candidiasis is the first condition that we are going to discuss today. So this, we know that Candida is a commensal. It resides in the oral mucosa and in the genital mucosa, and this colonization takes place within 1 week after birth. So children, the babies, newborn babies, they start coming to you within 1 to 2 months, and the presentation is in the form of these curdy, white, stuck-on plaques in the oral mucosa, which you can see on the gums, around the lips, and inside the buccal mucosa. So what are the factors which give rise to this oral thrush? Basically, this this is caused due to a colonization of the infant's mucosa from the mother's nipples. And sometimes we know that parents, they give soothers to the babies. And if the soother is not cleaned properly, then that enhances the risk of this colonization. We use antibiotics for treating any URI or any infection in the baby, and that also predisposes to candidal infection, and inhaled corticosteroids. So sometimes beyond infancy also we see this oral thrush in those who do not maintain a good oral hygiene, and these children, they use inhaled corticosteroids. And mind you, so when you refer to the dermatologist, severe and recurrent thrush, which is not responding to the usual routine treatment, can, point towards an underlying immunodeficiency. And it can also be a sign of underlying diabetes, especially the vaginal candidiasis. And we have seen children, 3-year-old, 4-year-old, coming with vaginal candidiasis. And the treatment, first and foremost, you have to tell to the parents that soother should be properly cleaned, should be boiled in water, and the oral rinsing with water, warm water for the baby, and nystatin suspension, or even clotrimazole and miconazole lotion can be applied. To children who are more than 3 years of age, clotrimazole troches can be given. We do not recommend treating simple cases of oral thrush with fluconazole, because it runs the risk of increasing resistance to fluconazole. So resistant thrush, if you see, so take home would be that you refer further on to the dermatologist or infectious disease specialist. Now, these are some of the other case scenarios which we see in the candidal infections. So this is also a common one. This is angular cheilitis. Now, angular cheilitis, candida is one of the offenders here, besides many other factors which lead on to this condition, such as lip smacking, thumb sucking, and dribbling of saliva from the angles of the mouth, vitamin B deficiency. So it's a multifactorial condition, but candida does play a role. So the treatment would be to keep the area dry. As I said, that moisture of the skin for very long period of time, persistent moisture, can give rise to colonization by candida. So we have to use antifungal creams followed by steroid creams. Now, this is, I think, again, a very familiar scenario where you see this erythema, maceration of the fold in the axilla, and you can see that there is maceration here in the skin. Now, this is a case of candidal intertrigo in the baby. Again, it is treated with the help of topical antifungal creams for a period of 1 to 2 weeks, and then we have to manage the moisture in the body folds. We have to keep the area dry. And now I come to candidal diaper dermatitis. So diaper dermatitis again is a condition which is difficult to manage, since infants and babies, they generally continue to soil their diapers, as because they have infants have the gastrocolic reflux, and then sometimes parents also the caretakers also, they forget to change the diaper frequently and maintain the dry skin. So what happens, that candida again becomes active in this area, and generally we encounter this condition in babies who are from 2 months to 4 months of life. So I just want to bring your attention to the area. As you can see, there are some pustules around in the periphery of this red area, which has developed in the crease of the thighs. So the fold involvement is very important. And you can see that besides this crease, which is red, there is peripheral redness along with these pustules, which are known as satellite pustules. And this constitutes the pathognomonic clinical finding to diagnose diaper dermatitis as candidal dermatitis. So how are we going to treat this condition? We have to reduce the skin maceration. We have to ask the parents to frequently change the diapers. There should be diaper off time in between. The baby should be just exposed to the hot air of a fan or kept in the sun without the diaper. Topical miconazole cream is useful, and we can also use zinc oxide in petrolatum base because there is some inflammation over there. But idea is to avoid potent steroids, because this area we just simply prohibit the use of potent topical steroid creams, because there is a very quick absorption of topical steroid from the diaper area due to occlusion, and the role of even 1% weak hydrocortisone is also not very clear. So just restrict yourself to the above 5 principles of managing diaper dermatitis. So now what we have to do is, this is the counseling we have to give to the mother or to the caretaker. Clean the skin, air out the skin, use barrier ointments like zinc oxide. Disposable diapers should be, kept off. There should be a diaper holiday in between. And this counseling has to be given by the pediatrician who is seeing a baby with diaper rash, because the counseling is very important. And now, how can we differentiate this diaper rash from irritant diaper rash? As I said, diaper dermatitis is an umbrella term. It can be caused by different conditions. Different pathological conditions can cause diaper dermatitis. We just heard about candidal. How do we differentiate it from a simple contact dermatitis, which is the irritant dermatitis? Is that in yeast, because it is an infective condition, so the redness will be quite dark. Here it is mild redness. You see satellite lesions in candidal diaper dermatitis. It involves the inner thigh. It does not respond to the routine treatment and needs antifungal treatment. So next condition we come to is the cradle cap. So cradle cap, as you know, that it is caused by a buildup of dead corneocytes on the scalp, and usually it is again seen from first month of life onwards, and it is there. It peaks around 3 months of age, and the babies are brought to us with thick, crusted, greasy, yellowish scales, which are stuck up on the vertex and on the frontal region of the scalp. So this is again a very common scenario. But what information as a pediatrician, or what knowledge we should have, is that this is asymptomatic, and in general it's a physiological over activity of the child's sebaceous glands over the scalp under the effect of maternal hormones. So we know that the maternal hormones after birth, they are going to cause certain changes in the skin of the baby, and this is one of them. And this is going to be a self-limiting condition. But When the condition is severe, then these greasy crusts, they can spill over the other parts of the face. It can involve the eyebrows, forehead, eyelids, the nasolabial folds, the postauricular area, and so much so other areas such as the umbilical area, the diaper area, and the other body folds. So this is then that becomes a severe case of seborrheic dermatitis. And in rare cases, sometimes it may manifest as erythroderma. Erythroderma is when the skin becomes red and scaly. Almost about 80% of the body surface area is red and scaly. So that's a rare situation. But in case you are seeing a widespread seborrheic dermatitis kind of picture in association with this cradle cap, so your job as a pediatrician is to examine, look at the other areas, look at the forehead, look at behind the ears and the other body folds. So in case it is there and it does not respond to your usual management, then you think of immunodeficiency, some underlying immunodeficiency, or some vitamin deficiency. And how are we going to treat this cradle cap is simply, we know that it is not infected. It is just a buildup of the sebaceous secretions and the dead keratinocytes. So we just tell the parents that the baby's scalp should be washed daily with a gentle baby shampoo. And at night, we just give them some thick lubricating material. It could be a oil, coconut oil, olive oil, or white petrolatum, which is to be applied by the mother over the scalp at night so that the scales, they become softened up and they become loose. And the next day morning, the scalp can be washed off, followed by gentle removal of scale with a soft toothbrush. And oil application helps in softening. But in case it does not improve after this conservative treatment, then next step is to give either ketoconazole cream, because what happens that there is some role of Malassezia furfur in causing seborrheic dermatitis or cradle cap. And if the inflammation, if there is a lot of redness, then sometimes a mild topical hydrocortisone cream can be given. So that depends upon the severity of the case. So now we come to the next condition, which is now almost turning into an epidemic in adults. So that is why we are seeing many cases, pediatric cases also. And this is tinea corporis. Now, tenias are commonly known as ringworm infection, and they are caused by the dermatophytes. So dermatophytes, we have three genera: Trichophyton, Microsporum, and Epidermophyton. So these are the causative organisms, and we know that these infections are highly contagious and infectious. So close contact with an infected schoolmate, classmates, somebody in the family, sharing of towels, sharing of articles, and not maintaining a good hygiene or sharing of clothing also can give rise to this infection in the children. So it is transmitted by direct contact with infected humans and also by fomites. So as you see here, I think everybody is able to recognize these ring-shaped lesions, because you see the border is very active. There is erythema, there is papule, vesicle, and there is some scaling, and the center is cleared up, but the skin is still erythematous. There is post-inflammatory hyperpigmentation. So the patches have healed at one place, appeared at other. This shows that the infection has been going on for quite some time and the treatment has not been adequately given. So this again raises the question as to how to treat. Now, we have to use a topical antifungal agent in case there are the diseases localized to just 1, 2, or 3 patches, or maybe if 1 or 2 regions are involved and it is not widespread, we can use topical antifungal cream. It is to be applied twice daily for minimum period of 2 to 3 weeks. And we recommend now that it should be at least extended 7 days beyond the complete resolution of the lesions. So once the lesions have resolved, you have to continue, because that diminishes the risk of relapse. And we can use any topical antifungal. We can use clotrimazole, ketoconazole, terbinafine, miconazole. They're all equally effective. But the only thing is, do's and don'ts of sweating has to be avoided. Body hygiene and no sharing of any clothing or article has to be emphasized upon. Now, another important thing is, please do not use topical corticosteroids here, and please avoid prescribing them, because they can play havoc with this condition. So that is why the organism becomes resistant. So this is only to highlight that we are seeing tenias in babies also. Like you can see this erythematous scaly patch, which has got a border on the face. This is tinea faciae. Infants also are not spared. And how do infants acquire this infection? Is from their mother or from the father. Somebody who holds them has tinea on the face, tinea barbi, or tinea around the neck. So resulting in this erythematous scaly lesion on the face. And how do we diagnose? We just do a scraping. We do a scraping. It is just to educate you on this, that from the border, scaly border, active border, we do take the skin scrapings and we examine in the microscope, under the microscope, by keeping these scales in 10 to 20% KOH, and you see these refractile, branching, septate hyphae, which are classical of dermatophytes. So this is another case to show. This was a 10-year-old boy who had this patch of tinea on his neck. And here you can see that you have to look at the other areas of the body also. Patient shows you one patch, but you have to actively ask about any lesion and must disrobe the patient to look at the other areas. And there are hidden patches, because your treatment will be decided upon the extent of the disease. And here you see erythema is not so much present, but you can see that there is brownish discoloration and there are fine scales. So this is chronic dermatophytosis. Patient has not taken treatment. So think tinea when you see scaly, itchy plaques. Scaly, itchy plaques, they can be brown, they can be erythematous, and they can be anywhere on the body. And another message is, please do not use topical corticosteroids over these lesions. Now we come to the other superficial infection, that is pityriasis versicolor. So again, I think everybody has seen these lesions during the summer season over the trunk, neck, and the back of the children. And generally, the common age group which gets affected by this infection, they are the adolescents, because they are more physically active, they participate in sports. So what happens is that pityriasis versicolor is again caused by malassezia, which is a normal resident flora of our skin. And if the environment is conducive for its proliferation, that is, when the oil on the skin is there by external application, or during adolescence when the sebaceous glands are active, this yeast, it starts proliferating, it invades the stratum corneum, and it causes these hypopigmented patches, or sometimes it causes brownish hyperchromic patches also, but they are scaly. Now, this is again asymptomatic infection. The patient, the child, does not have any symptoms. And what you have to do is, you have to again describe and counsel the patient regarding basic measures of hygiene, avoid sweating, avoid tight clothing, nylon clothing, avoid oil application. So here it is very important to emphasize upon avoiding application of oils externally on the skin. And we give topical ketoconazole. We can also make use of selenium sulfide. These are all antifungal lotions that are there. So how do we tell the parent to apply this? Selenium sulfide comes as a shampoo, as you all know. So we just 1:1, we dilute and this lotion is applied on these patches for about 15 to 30 minutes, nightly application for about 2 weeks, and then once a month for 3 months. Another important point I would like to mention here is that this is again an infection which is resistant. It keeps on coming back. Recurrences are very common. It leaves behind hypopigmented patches which can confuse the clinician with vitiligo. So these points have to be kept in mind, and the diagnosis is again based upon microscopy. As you see, there are small spaghetti and meatball appearance in the KOH preparation that we see. We also see this infection in infants and in very young babies also. On the face, these multiple tiny hypopigmented patches, which signifies pityriasis versicolor. Now, another form in which this infection can appear is in the form of follicular lesions on the back, and it is again caused by malassezia known as Pityrosporum folliculitis. So, general case scenario is that usually adolescents, they come to us with these multiple erythematous papules and pustules on the back, shoulder, and sometimes on the face. This is also known as fungal acne. And this is not the conventional acne that we see, but it mimics acne. And there is presence of pruritus in this condition, which is not present in the general acne. So that is one distinguishing point here. And this usually develops following antibiotic therapy or following some immunosuppression. This is a common preceding factor that is seen. And again, it is treated with the help of oral or topical antifungals. Mind you, antibiotic therapy over here will not help. So you have to be sure that you are dealing with the Pityrosporum folliculitis and not acne by just asking a simple history that is there any pruritus, and if there is pruritus, then it is more likely to be folliculitis rather than acne. So this is just a chart to tell you that many topical antifungal preparations are there, and they're more or less the same in their efficacy. Like you have clotrimazole, ketoconazole, miconazole, terbinafine. The newer antifungal agents, they have more of anti-inflammatory effect also. So, and less side effects, so we use them more often in the pediatric age group. Now, again, very important slide for all my pediatrician friends here, that we know what tinea looks like. That is a ring, but not all rings are tinea. So that is also a very important thing to bear. So which other lesions can look or mimic tinea? Now, this is psoriasis. We know psoriasis is a very plum colored, salmon pink colored. You see the darkness of the color. The hue is darker. You see the scales all over the patch. It is studded with these whitish scales on the surface, whereas in tinea, it was just at the periphery. So this is psoriasis, and psoriasis is generally not itchy. Tinea will be very itchy. Then we have pityriasis rosea, again ring-shaped patches, but they are present on the back. They are not so erythematous, and the scaling also will just be collarette of scales. So around the patch, there will be some scales present. You have nummular dermatitis. You see coin-shaped lesions, and they will again will not show an active edge, and they will have these surface changes in the form of scales and crusts. And this is a kind of an eczema, which we see in the pediatric age group in those children who have a history of atopy. Then we have granuloma annulare, which is a granulomatous condition. This is completely asymptomatic. You see these ring-shaped lesions, and there is no scale. They are deep-seated lesions, and they are asymptomatic. So remember these four conditions which you need to keep in mind. Then we come to tinea pedis. Tinea pedis is not so common, not so very common in the pediatric age group, but adolescents, it starts, setting in because of, again, their physical activity, They run around, they participate in sports, they remain in closed footwear for very long time. So they have sweaty feet. So this condition generally in prepubertal children we will see, and they come to us with this peeling of skin. As you can see, there is scaling, there is cracking, and there are fissures. These are the abraded areas of the skin, usually present between the toes. So this variety is known as interdigital type of tinea pedis. So what are the symptoms? The condition can be itchy, and sometimes the patients say that there is some burning over there, and it's a contagious condition. It happens because of sharing of socks, shoes, and by walking barefoot on the swimming pool floor. So by close contact, by sharing of footwear, so that is very important, and sweaty feet, they predispose, as sweating leads to maceration. So some more pictures for you to identify between the toes. There is this grayish, macerated, sodden appearance of the skin with some erosion here, and this infection is now involving the dorsum of the feet also. As you can see that there is the serpiginous border of the plaque, which is occurring on the dorsum. Now, this is another type of tinea pedis. These are the morphological manifestations. Now, here you see that there is erythema around the sole of the feet, and along with scaling involving both the feet. So this is known as moccasin kind of tinea pedis. If we do a KOH from the scaly portion of the plaque, it will show high feet. Then there's another variety of tinea pedis, which is known as bullous tinea pedis. As you can see, the children, they come with multiple dense, deep-seated blisters, and which heal with desquamation and scaling, and there is burning and there is itching in these lesions. So these are the three manifestations of tinea pedis. How do we manage? So first and foremost, as I said, that you have to give the basic measures and counseling to these patients and the caretakers to wear cotton socks, which absorb sweat, keep the feet dry, wash your feet daily, put antifungal powder, avoid sharing footwear, socks, and wash clothes. These are very important precautions, because if these are not exercised, then these infections, they continue to recur. Avoid tight footwear, and also we have to insist upon that the feet are dried very carefully, especially in between the toes. How do we treat? We give antifungal agents, and we can use simple, cheaper options. We have Castellani's paint. We can use topical antifungal agents. So there's a huge variety basket of agents which we can choose and pick. And you can also use terbinafine, amorolfine. And in case the patient does not respond to topical, then you have to use oral antifungal agents. And you have to use for 2 weeks to treat these infections. Then coming to tinea capitis. Tinea capitis is the most common dermatophytic infection in the pediatric age group. It generally involves children between 3 to 10 years of age. And mind you, remember that after puberty, it is not seen, because after puberty, the sebaceous glands are secretion has antifungal, we do see in immunocompromised children. So clinical presentations can be non-inflammatory or inflammatory. Non-inflammatory can be gray patch, black dot, and diffuse scaling. This can be there. And it has to be differentiated from seborrheic dermatitis, psoriasis, dandruff. And in the inflammatory forms, the scalp appears red and swollen, and this can lead to permanent permanent scarring hair loss. So let us have a look at the pictures. As you see, these are gray patches. Loss of hair in patches and with scaling, giving rise to the term gray patch hair loss. Tinea capitis, again, similar, where the hair, they have fallen off Black dot, as you can see, tiny black dot wherever the hair has broken at the surface of the scalp. You see this inflammatory tinea capitis in the form of an erythematous boggy swelling over the scalp studded with pustules. This is extreme case of type of tinea capitis known as favors, where there are stuck on yellowish crusts. It can mimic seborrheic dermatitis. So again, very many manifestations are there, inflammatory and non-inflammatory. Now, this slide shows you a simple technique to look at the features of tinea capitis with the help of a dermatoscope. So you will see coma hair. This is the coma hair. You will see many broken hair. You will see flame shaped hair. So the corkscrew hair are very commonly seen. So this can give you a clue that this is tinea capitis. Now, chirion is very common. Chirion generally is caused by a zoophilic species of dermatophytes, and it leads to a lot of inflammation. If it is not treated with the help of oral antifungal, it can lead to scarring, hair loss. So pediatricians should be aware of the scalp conditions also. In case they see any patchy loss of hair with scaling, then they must refer the child, because it requires proper treatment. And the confusing conditions with tinea capitis are alopecia areata. But in alopecia areata, it is a smooth bald patch. There is no scaling, there is no erythema. Trichotillomania is another condition in children, which is again a behavioral disorder. The child plucks at the hair. There would not be any erythema. There would not be any scaling. So these are certain, clues to the diagnosis. How do we treat tinea capitis? Always, first, very important, we must do a culture here, because the treatment choice of oral antifungal will depend upon the species. And we also have to do clinical examination, trichoscopy, and KOH. It always requires oral antifungals. It cannot just be treated with topical. So we use either terbinafine in case of Trichophyton transferans species, and for microsporum, we use better is to use fluconazole or itraconazole, and it requires longer. 4 to 6 weeks is the minimum. Sometimes we have to give up to 8 weeks also, along with antifungal shampoos, which will keep the load of spores low, and it will help in reducing the recurrences. So then we come on to the next is onychomycosis. So onychomycosis again is a general term which describes the fungal infection of the nails. Now, fungal infections per se in nails in children is less common than in adult population. Why so? Because in children, the nails grow very fast. So the infection cannot simply settle down there. The nails are smaller in size, so the area for infection is less. The trauma, because they generally do not indulge in the household activities, so the trauma to the nail plate is less. Hence, we encounter them much less commonly in children. But nowadays, they are common because since the dermatophytosis has become sort of an epidemic these days, so the infection, the dermatophytic infection, it travels from the body surface or from the feet onto the hand, and then gradually can involve the nail also. And some immunodeficiency underlying, like it is commonly seen in HIV children, HIV positive children, or some immunodeficiency. So you do encounter. Toenails are more commonly involved. And tinea unguum is a specific term where it is caused by dermatophytes. Even candida also can cause onychomycosis, and especially in children who are immunodeficient. So there are different types of onychomycosis depending upon which part of the nail plate gets involved first. It can be distal if it involves the distal part of the nail plate. It can be superficial if just the superficial part of the nail plate, proximal, endonex, and the total involvement of the nail plate leading to complete destruction is known as total dystrophic. So these are the morphological patterns, and what it looks like is that the nail plate becomes crumbly, and you can see that there is this yellowish discoloration in the distal part of the nail plate in a young child of about 8 months. And here you can see some paronychia, erythema of the nail fold also. You can see pus formation. So paronychia can be superimposed with acute bacterial infection. These two can coexist, candida along with a staph infection in them. And this is onychomycosis. As you can see, there is yellowish discoloration and crumbly nail plate, dystrophic nail plate. So this is a sign of tinea unguum. Yellowish discoloration is very common. As you can see, the distal nail plate has been eaten up. There are some scaly subungual. Underneath the nail plate, there are deposits, and there are friable patches white. This is superficial white onychomycosis. So these are some of the pictures. Again, if there is involvement of the matrix of the nail plate, and if the nail plate is more than 50% of the nail plate is involved, then we have to give oral antifungal. We use terbinafine or itraconazole. Terbinafine is dosed based upon the weight of the child, and we can use itraconazole. Itraconazole is more broad spectrum, and it works well on the molds and on the candidal infections also, and it is given in a dose of 5 milligram per kg per day. You can give continuous therapy or you can give pulses. So for the fingernail infections, you give treatment for 8 weeks, and for the toenail infections, you give treatment for 12 weeks. So coming to now, just a point which I want to mention here is that oral drugs, they have a potential hepatotoxicity. So when you are giving oral drugs like terbinafine and itraconazole, baseline transaminase evaluation must be done. And itraconazole, generally, we do not use it as a first-line therapy for tinea capitis. We rely more upon terbinafine and fluconazole. So coming to some of my last slides, coming to subcutaneous mycosis. Now, subcutaneous mycosis are more invasive, and they usually happen after a child sustains a skin injury in the form of a thorn prick or some splinter. And these fungi, they are in the soil and generally seen in children who walk barefooted. So mostly in the rural areas, who are in the farming occupation. So these infections, they are more deep-seated, such as chromomycosis, mycetoma, sporotrichosis, and in OPD, they are not encountered so very commonly because they are chronic and they go on for months and years together. And what do they look like? They can be in the form of subcutaneous nodules in case of pheohyphomycosis. These are all saprophytic fungi which enter into the deeper layer of skin through injury. Now, this is chromomycosis. As you can see, this is also known as verrucous dermatitis, and it mimics tuberculosis verrucosa cutis. It mimics warts when it is in the initial stages. So you will see these nodules, verrucous nodules, and sometimes ulcers also. It can involve the underlying bones also. This is just to show, but these are not generally seen in the OPD. You should also remember sporotrichosis, which is again in the lymphocutaneous spread is there. So the linear nodules with lymphatic enlargement is seen, and this happens due to a Sporothrix schenkii, and usually in plant handlers it is seen. And so coming to my last slide, I would like to conclude by saying that fungal infections are on the rise in children also, and there are different manifestations. So like if you have immunocompromised children, HIV seropositive children, so we often encountered cryptococcosis, and the skin manifestation can be in the form of these umbilicated papules, which mimic molluscum contagiosum. And superficial cutaneous infections, I think I've dealt with in detail. So you must be able to recognize them. There can be different manifestations. You should be able to recognize the superficial infections and treat them and know when to refer. Must suspect these infections when the lesions are long-standing and non-healing, because sometimes they can become systemic and they can complicate, like causing cellulitis and other infections. So this brings to the end of my session, and thank you so much. We can entertain questions if there are.
Well, for such a wonderful presentation, please stop sharing your screen.
Yeah.
I request Dr. Bajania sir to please say a few words. Then we'll have the question answer.
Yes, sir. In fact, I was listening to Madam and it was really spellbound. I
Please
wish
stop
that
sharing.
I wish that I had such type of teacher during my residency days. I mean, for 3 months, uh, like exposure to pediatric dermatology. In fact, she covered all the possible pediatric dermatological conditions, and it was a very comprehensive science. And I'm really so happy that all the participants, I'm very sure that all the participants must have derived immense basic knowledge of routine pediatric dermatological conditions. Of course, the rare conditions, difficult conditions, as Madam said, I mean, they can be referred to dermatologist, but most of the common conditions, they are covered. I think Madam can give some of the common commercial names also without conflict of interest to the participants, so that that would be more easy.
We will share them in the group.
And second, which medicines to be avoided, like especially the abuse of
Steroids.
steroid cream in dermatological conditions. I mean, so thank you so much again, Delhi IIP, for this wonderful session. I'm privileged and blessed to have you all around, and all the best to future participants for further lectures in upcoming series. Thank you, Dr. Ajay Gupta, sir. Thank you, Alok, sir. Thank you, Delhi
Welcome.
IIP.
Though most of the questions have been answered by Dr. Amit. He is senior resident, Kalavati Children's Hospital and Lady Harding Medical College. And sometimes after a episode of diarrhea, acute gastroenteritis, there is a rash in the gluteal area. So how do we differentiate? Like this is just a contact gastroenteritis or a fungal infection?
So, if you have a clear-cut history of a diarrhea which is preceding the rash, then it is most likely contact irritant dermatitis, because we know that there has been a soiling and there has been an extra wetting of that area. So, it is most likely to be that, and we can just use zinc oxide. We can use barrier creams, keep the part dry. And if at all, if the redness is really too much, we can use just 1% hydrocortisone cream. But if the condition has been there beyond 3 to 4 days, then we generally presume that candida has set in. I mean, because it is a commensal, it is in that area. You are giving the soil for the candida to come and sit there. So then if it is beyond 4 days, 5 days, then we have to, make use of topical antifungal cream over there. You can use terbinafine also, because it is not irritating like clotrimazole or miconazole. But first and foremost is that preceding diarrheal this thing episode, it is most likely a irritant contact dermatitis.
Well, many patients of angular cheilitis, they come in the OPD. Most of these have a, say again, contact dermatitis because of drooling of saliva.
Yeah.
But when do we suspect a fungal infection?
Yeah. So again, as I said that in fungal infection, you will have, so generally we make use of an antifungal steroid cream. So first always give an antifungal cream. You have to know that you have to also, examine the child in totality. You have to take the history, isn't it? You have to take the history.
Yes.
So if you suspect vitamin deficiencies, you have to supplement the vitamin, this thing also. At the same time, once the condition has occurred, you have to avoid the dribbling. You have to tell to the parents that they have to keep on, give wipes to the child so that the area can be, kept dry. And it is better to use first an antifungal. And if it doesn't respond, so the second thing which comes is the topical steroid. Don't give topical, because topical steroid has become such an over the counter preparation and handy that we are just simply kind of prompted to use
it gives
that.
a symptomatic relief. Parents are happy, doctor is happy.
Yes. Or you can simply use this GV paint. GV paint will be Castellani's paint and GV paint, they have antifungal and antibacterial both. So you can, but I would never recommend a steroid first.
There are many antifungal powders available in the market, and people tend to use them in the summers. The summers are, and people, they come and we are using this powder. So what is your take on those antifungal powders?
The antifungal powders, the purpose was that they would absorb the sweat. So once the secretion is there, secretion is going to be there. So it will absorb the sweat. Only thing is that people, after using powder, dusting the powder, they forget to remove the layer of the powder that forms before the second application. So maintaining that is very important. I would recommend use of powder only in case of tinea pedis, where there is hyperhidrosis of the feet, where the child, most of them, they would be wearing shoes most of the times. So they have to clean the feet, dry the area first. That is very important. You have to tell them that most of the people after bath, they'll just dab the powder, it cakes up, it forms a layer, thick sticky layer on it, and that is more harmful. So we have to tell them that they have to first dry the area. I would recommend only for tinea pedis in case of sweaty feet in between the toes. So that is where it should be given. But in case, like some people, they do not, like some children would not have an infection, it can be used as a maintenance. But at the same time, you tell them, like for tinea cruris, we get lots of adolescents with tinea cruris. In the crural area, in the thighs, in between the thighs, there is redness. So those of them who are, intelligent enough, we would tell them that they have to dry the part. After bath, dry the part, and then they can put sprinkle the powder to reduce the friction. And next time when they bathe, they again have to remove that layer of powder which is there very properly, and then use powder again. So it comes with caution. It comes with caution.
Thank you. Dr. Sunita wants to ask a question. Dr. Sunita, would you like to ask your question? Dr. Sunita?
I think she has raised hand by default.
Okay. Then most of the question, ma'am, if glycofulvin is not available, what should be given?
We can use terbinafine. Terbinafine is good. Yeah. We are rather, relying more upon terbinafine now because it is a fungicidal agent. Glycofulvin is a fungistatic agent. So you can use terbinafine depending upon the weight. And very young children, you can use oral fluconazole. That is safe. Although they have launched itraconazole also, but itraconazole, I'm not very, this thing. I would not recommend it as the first line because it does have its own toxicities.
As pediatrician, should we take this scraping for QH preparation and send it to lab or send it to dermatology?
Yes. I think you can send it to the lab also. That's what, sometimes we also do. Many a times, like in our side lab, we are not able to, isolate or see the fungus. And just to make sure that it is done properly to the micro lab. And from there, sometimes we get a positive result from the lab. So you can clean the area with the sterile swab, with a spirit swab, and collect those scrapes with the help of a blade in a paper, fold it, and send it to the lab. You will get the
collect it on a paper.
Yeah, in a paper.
And how to differentiate between lesions of granuloma from tinea?
That is actually, it requires little experience, but the visual signs, first of all, in tinea, since it's an infection, there is inflammation, so you expect to see redness. In granuloma, there is no infection, it is just a granulomatous, non-infectious granulomatous disorder, so there is no redness in the lesion, and it is skin colored in case of granuloma. And in case of tinea, there would be other signs of inflammation, like in the border, it will be active. There will be papule, scale, there will be papule, vesicle, and scale. Whereas in granuloma, it will just be a thick, raised, indurated border without any redness, without any vesicle, and plus asymptomatic. There are no symptoms in granuloma. Child is fine. Parents notice it. This patch is, they have noticed. But whereas in tinea, if you ask, you have to find out whether there is itching or not. So in tinea, it is extremely itchy. So anything itchy, erythematous, scaly, annular, think tinea first.
Many people, delegates have asked treatment of pediatrics versicolor again.
Yeah. So first is that counseling. I said that they have to tell the parents, give a ketoconazole soap for bath, because the child has to be told not to apply oils. Very popular practice in our country, coconut oil, mustard oil, and everything. So oil application is to be stopped on the body. Number 3, you have to use topical either selenium sulfide shampoo, which is there, Selsun shampoo is there, you have Candid TV. I'm just naming these preparations. Lotion application is better because spreadability is good of a lotion. It's a widespread area on the trunk, on the chest, on the back, patches are there. So you dilute the lotion 1:1 with water, apply that at night for about half an hour, followed by removal, or the next day morning, the child can take bath. Give it for 2 weeks, and after that, once a month for 3 months. That is how we treat. And we also use antifungal shampoos because we want to reduce the spore load in the scan of malassezia.
Yeah. And some comments on the common prickly heat, because summer season is approaching. Many.
Yeah, so prickly heat, again, we have to first of all those general measures, that no occlusive clothing, tight clothing where the sweat remains in contact with the skin. It does not get evaporated. So they should be given cotton clothes, airy clothes, clothes which make your skin breathe. Number 1. Number 2, bathing they can do twice a day, because the sweat gets removed. So that also leads to cooling. Number 3, we generally make use of calamine lotion in case there is just this sweat retention is there. So just simple calamine lotion, cool calamine lotion 3 times a day is very good. And in case there is some secondary infection, you can also use oral antihistamines if it is itchy. And prickly heat powders, generally they are soothing, but as I said, again, caking can take place in summers very easily. It forms a layer. So I prefer to use Dermocalm lotion, calamine lotion, and antihistamines. If it is infected, then we have to use antibiotic, oral antibiotic.
Right. Thank you for a wonderful discussion.
Thank you so much.
Dr. Bhandari sir again with us. President, I request him to say some closing comments. Please unmute, sir. Dr. Bhandari sir, your comments.
हाँ जी, हेलो डॉक्टर डॉक्टर बजानिया हैं सर?
हाँ जी, he is there.
Yes, sir, I am here only.
तो सर आज तो माइक हम आपको ही देंगे, आप बताइए सर बाकी चीजें. It has been really nice to have Dr. Bajania here with us. He is a internationally renowned pediatrician and with our special interest on environment and child health. Done lot of work and he keeps updating us on that. और आज हमने इसीलिए इनका dermatology वाला रूप भी देखा है, and we really appreciate that you have taken out time on this Sunday morning to be here with Delhi IAP. And gradually, sir, Delhi IAP is academic capital of IAP also. We have 38 institutions who are conducting postgraduate courses in various, in pediatrics, में DCH, MD, DM and DNBs and all. And gradually, shortly, we'll be touching the figure of 40. And 40,000, 45,000 pediatricians को represent करने के लिए, every leading pediatrician of the country has had an academic stint in Delhi